Dr. Debashish, Head of the Department Neuro, Dr. Debashish Chowdhury. I would like you to welcome the doctor session and please say something for 2 minutes. Aap aaiye.
So, good afternoon, ladies and gentlemen. I think this session is on the treatment part of multiple sclerosis to be discussed by various doctors who have come from Delhi and outside also. First of all, I think that when we, the MSSI came to me to conduct this program, so we thought that there should be some, education about the disease, about the disabilities, and about the rehab measures that can be taken to benefit the patients. And here I see in the group a lot of patients who are with us at GIPMER, also at AIIMS, and I think most of the consultants have a few of the patients who are sitting here. So they may be well conversant with the general idea of the disease. Before we begin, and I invite the panelists for this program, I will give my brief introduction. So I am Dr. Debashish Chowdhury. I am the director professor working at GIPMER Hospital. I was the past president of Indian Academy of Neurology and past president of Delhi Neurological Association. And I generally have, my basic interest area, focus area of interest is headache disorders. But I do have significant interest in demyelinating disorders, and we run a MS and neuroimmunology clinic at GIPMER. So we have got a lot of patients attending that clinic, and I think that many patients have been benefited through our services. So I have the pleasure of inviting Dr. Rajesh Iyer. Dr. Rajesh, please. And they are all my colleagues, and we have been meeting off and on, bumping each other at various conferences in the last 2 decades or more. So he is the chief neurologist at Manipal Hospital from Bangalore. Dr. Kameshwar Prasad has come? No, he is not here. Okay. Dr. Rohit Bhatia, a very, very dear friend of mine. As you know, that he has been instrumental in starting the MS services at All India Institute of Medical Sciences along with Dr. Padma. And he has the credit of running the MS registry with an ICMR project, and they are collecting the data of MS patients and other demyelinating disorder patients throughout the country. And Rohit is a very, very fantastic clinician and is a very, very good friend of mine. And then we have got Dr. Vineeth Jaison from CMC Ludhiana. Has he come? Yes. Vineeth? Yeah. Right. So, he's a young neurologist from CMC Ludhiana. He has got special interest in demyelinating disorders. Again, my close friend, Dr. J.D. Mukherjee, who is heading the Department of Neurology at Max Hospital, a director there. He is multifaceted, but I think he has got his main interest in demyelinating and neuroimmunological disorders. Dr. Netravati, she is the rising star in the demyelination field in India, and she has been in demyelinating disorders from NIMHANS. And we have had, when I was the president, we had a lot of opportunities to conduct online programs through Netra for the entire community, for the doctors as well as the patients. Professor Manjari Tripathi, she is now heading the department of All India Institute of Medical Sciences. Originally an epilepsy person, but I think she has got interest as well of MS and related disorders. Because these disorders are now increasingly picked because of the advent of the neuroimaging. And I think Mittal, I think he has already spoken in the earlier session, so I don't think he'll be here. So I think that most of you who are here know about this disease. You have been communicated, you have been counseled about the disease, but still in the busy OPD, I think it becomes difficult to answer all the questions by the doctors. And many a times new situations and new challenges emerge, which might not be addressed very well by your respective doctors or their team. And so hence this is an opportunity for us to discuss some of these issues. The first, of course, I'll go to Rajesh, and I'll say that it has been talked about that there is so much delay in the diagnosis of MS. So what's your impression on that? Why there is this delay?
Yeah, so before going to why there is a delay, I would like to say that treating MS is like playing a T20 match. The first 6 overs decide who's going to win. MS also, it's very important that we get the diagnosis at the earliest and treat with the most appropriate medicine at the earliest so that there is victory and there's no disability. Now the delay in diagnosis is basically because very often the symptoms which initially happen tend to recover by themselves. For example, many people have some paresthesias, it goes off. Optic neuritis often gets recognized only when the other eye is closed for some other reason. It might be a silent kind of symptom. And then initial symptoms are often ignored either by patients or even their primary care physicians. So the awareness about the disease is very low among the non-neurology community. And even among neurologists, very often, when somebody comes with paresthesias, you think it would be something peripheral. Or we don't tend to seriously think of MS as a differential. And sometimes in a busy OPD, we don't examine the patients also in full length. So it becomes very important that all these symptoms, we always need to keep in mind a possibility of a differential that very often the non-neurologists don't do. So we need to strictly inculcate the concept of MS in MBBS curriculum right away, so that as students we were never taught about MS during MBBS days. So if we are aware of that, if the next generation of MBBS students become aware, probably at least they will think that okay, this could be a possibility and think of doing an imaging.
Yeah, so I think awareness is very important, and I think any sudden neurological symptom or sign, if you are developing or some of your relatives or some of your known tos or anybody in general is developing, is a cause of concern, and you should always seek a proper neurological opinion and consultation, because that will save you the delay. Because what happens that initially some of these symptoms may be transient, lasting for a very short time, so you ignore them, but then they recur and then it becomes quite late. But often now I have been told in my outpatient clinics, Dr. Rohit, that we went to the doctor, he suspected something is in the brain, but he could not differentiate between MS and other demyelinating disorders. So what's your take on that?
तो मेरे साथ भी होता है.
No, so we all learn that's true.
So see,
The patients are confused actually at that time.
so yeah. So see, what happens is that, let me start with a very simple example, which I think most of patients sitting here may have had an experience, is coming with a vision loss. That's, I think, one of the most classical symptoms, which is generally a symptom which heralds most of these disorders. And the three common disorders that a clinician at that time, after he's decided that this is not related to retina or not related to a vascular supply, is to differentiate between MS, NMOSD and MOGAD. And I think these terms are frequently spoken with the patients when we are trying to make them understand what is our concern. So I think as an optic neuritis, as a single symptom, as a clinician, I have to think of all the possibilities. So when I look at the presentation, I look at the age, I look at the gender, I look at the evolution, then I decide on a series of investigations that will help me discern the diagnosis. And I think the first investigation that most of the people end up doing is an MRI scan, provided they have ended up with an ophthalmologist or a neurologist who has suspected optic neuritis. Because we have seen the gap there also.
So you want to tell the patients that, nowadays, if you really want to diagnose, you need tests. That is one barrier, that getting more tests. You asking the patient that, okay, you need to do MRI, you need to do your bloods, you need to do your CSF. So there is a barrier there, right? So you need to tell them that you need to have those tests to diagnose MS properly. Is that right?
Yeah, so if you're coming with a symptom and a doctor is suspecting that you may be having a demyelinating disease, which we use as a broad term, it's like buying a car and you want to decide whether you want an Alto or a BMW is your choice. But so when we talk about demyelination, then the downstream differential diagnosis is extremely necessary. And why is it necessary? Is because your prognostication, the risk of recurrence, the outcomes and the choice of treatment are a lot dependent on what you are formally considering as the final diagnosis. Sometimes it happens that you have an event and everything is normal. Your MRI can be also normal, your blood test can also be normal, your CSF is also normal. So in that scenario, the doctor will discuss with you about a follow-up plan or a treatment plan based on what he best thinks that you may still be having. So doing these formal investigations are necessary and they are required to reach a proper diagnosis.
Correct. So Vineeth, there is one question that comes to the patient's mind is always a fear of its relapse. So how can that be accounted for from the patient's perspective, that do I have this as a relapse? Like for example, a sudden transient numbness I started having in my hands, or sometimes slight fogging in the vision, which has happened again. So they always fear, they will keep on coming to the outpatients. So can you allay their concerns on this?
So to define a relapse, basically it should be at least lasting for more than 24 hours. It is something that, and it should not, just sensory vague complaints won't be enough for that. So it is important that we follow up these patients and then they see, because one of the important differentials is whether it's a very transient symptom, it just happened and then it went. That should not be categorized as a relapse. Also, in these patients, every patient, first of all, the diagnosis once you have made of MS, we are saying that you will have a relapse. At least to the extent that if it is a RRMS type of MS, you will be having that, and we expect it. But we are always worried. If it's a relapse, we want to get treated. So if it is a short, transient symptom, don't be worried. That cannot qualify for us to be giving, admitting you and giving you IV methylpred, because many of these symptoms will resolve on their own. But if they are more significant, you start having weakness, or if you are having persistent symptoms which are not going away, those patients definitely would need treatment to improve those symptoms.
Yeah, so it's a double-edged problem, At the one hand, we are saying that do not ignore your symptoms, and when the symptoms do happen, we are saying don't get very much perturbed. So it's a fine balance. So you have to educate yourselves about that, what exactly is meant by relapse, and is it important for me now to report to my doctor? That is a very important, I think, concern, as well as because that might alter your treatment paradigm, your treatment changes may occur, and that's very important to understand. So next question to Dr. Mukherjee is this, that nowadays people read a lot, they Google and they find out about the disease, about the management, and now there are so many advancements that is happening in the field, in terms of treatment. So how do you, and what is the initial discussion, how do you approach this problem of offering treatments to a patient of multiple sclerosis?
So that's a very pertinent question. So I think we have to take the patient on board for the treatment management. So what I do is I give them the options, that these are the options which are available in the country. These are the options that we can do. These are the options that are available to us. Of course, I have to keep the profile of the patient in mind. It has to be customized to the patient's entire profile. Now, there is a patient who wants to become pregnant, for example. So I have to give her a different kind of medication. There's a patient who says, I cannot afford the costly treatment which is there. So I have to give a different kind of treatment. So first of all, I give them a differentiation, whether for the fire that is there in your eye, that the vision which is lost, I'll have to give you steroids, which most of them agree. The problem starts when we give the disease modifying therapy. There I have to classify. Some of them will ask for simple drugs, like the biosimilars. Some of them, when I propose them that this may not be so appropriate for you, go for the higher drugs. There's a cost is a limitation factor. So I have to factorize the entire gamut of management that we have to give. I customize to the patient. I have a discussion, and it goes up to 45 minutes to 1 hour when the first time I meet the patient. So that is how I initiate it.
So who chooses? The patient chooses or you choose?
It's a combination.
It's a combination. Okay.
Yes, I give them a fair chance to understand.
Now, I want to emphasize one point. Now, just like the previous session, it was mentioned that there are a lot of errors in medical practice. So yes, there are errors like any branch in life, any kind of profession. Medical science, you have to accept this, is not a pure science. So it's applied science, and a lot of medical science is based on the best possible assumption by the clinician, who is your best guide, right? It is not given on a tabular form, in a table form, that you have got these drugs and these drugs will be useful. Whether that drug, that particular treatment is particularly suitable for you, seeing all your profile, seeing your indications and contraindications, seeing your genetic makeup, everything taken together, whether that will be useful or not, that is the job of the clinician, that of the job of a very, very professional man. So you have to believe in him or her, right? And of course, the discussion is most important, and I feel that the patient choice is the most important choice, because after all, it's your body and it's your disease. You are going to take the drug. But then you have to believe that what the physician is saying is probably based on his vast experience on treating these disorders and doing the best for you. Okay, so the next question comes that, Dr. Manjari, that, nowadays MRI is all around, right? And MS patients, we often ask that, okay, get the MRI brain done, MRI spine done. So how do you see your position as a clinician, that how to depend on those MRI findings, and what should be the quality standard for those MRI films that you see, because that can make or break a diagnosis?
So definitely, I think the first and foremost, thing which we look into is the history of the patient. And once we get the history, which makes us think that this could be a primary demyelinating disorder, and that too multiple sclerosis and its various types, we do request for certain investigations, and one of them is the MRI. Now, it's not uncommon that patients actually walk in with an MRI, and they come with films, and the films would not have the appropriate slice thickness of, between one area of the brain and the other, or they would not have the appropriate sequences. Now, MRI itself is a big, science by itself. So there are different sequences which you have. And we know now, even as we speak, there are such recent advances which are happening in the field of MRI, including seeing certain, minute details of the veins and the areas around it. So the sequences of these MRIs are also very defined. So if you do a suboptimal MRI, you may miss lesions, or you may pick up mimics which are not actually MS, but may feel or make the reporter, because the imaging is reported by a radiologist who may or may not know the clinical history. Very often it's just written MRI brain and the person is going for an MRI brain. So really, the clinical diagnosis will be based along with not just the clinical history, but the quality of MRI which the patient brings in, the sequences which are done, and also the duration after the event, that when they are done, whether contrast was done or not, and certain specific sequences which are there for multiple sclerosis, and also help us differentiate it from other disorders.
So right. So I think the point she emphasizes is that it's not just a matter of getting an MRI, but it's the quality of the MRI and all the sequences that need to be present to have a proper interpretation. And so I think that one question comes, and often I face this question in my outpatients. The patient says that, oh doctor, you see that compared to the last MRI, my lesion size or the lesion number has not increased, but I am feeling a little bad. I don't think that it's working well, for drug is not working for me. So, Dr. Netravati, so how do you, do you see MRI as a real biomarker, or is it just a surrogate marker that tells you about the general state of the brain having the disease, or does it have a great implication in your altering the treatment and management?
Thank you, Dr. Debashish. I think this is an important aspect, especially when a person with MS comes to us. He's on a medication and he says that I'm finding that gradually I'm either having limb stiffness, not able to walk as previously, or is having a lot of memory disturbances. So we do a repeat MRI, does not show much of changes. This is most usual stage, especially when they have gone into a little bit of further stage. That is, when the first diagnosis of multiple sclerosis is done, it's usually almost clinical and radiologically correlating. But with time, when you're on medications, we are not going to depend on just the type of lesions, the number of lesions, or enhancement. Now something called as a patient reported outcome. That is very much important. I am going to give credence to what a patient is telling. He is telling that on treatment he is progressing. He is telling that he is not able to walk properly. I think that is very, very important. I'm not just going to depend on the investigation. Listen to the patient. They are telling they are having symptom, and it is true. This discorrelation is very much there. And lot of research is being done now on patient reported outcome. And that time if we address, for example, patient is on a disease modifying agent, comes to you, tells that he's having a lot of fatigue. Please address it. You will see that the patient will show improvement. So let us not depend only on the investigations.
Absolutely. So you know, to the persons here about that, there is a lot of DMTs that are available now. So
मैं तो खुद confused हूँ. I'm just out of yeah, please go ahead.
medicine is a branch of confusion. Not to worry about that. So please go ahead.
No, so on a very natural disclosure, because as a doctor, I'm generally very open and frank with my patients.
But I'll make your task easy. Whether when you prescribe a drug, do you consider the efficacy part or the safety part? Which gets you the priority?
I think it's the balance. There is never a single decision that I would want to make. I cannot make a decision of a super aggressive drug for a female who has many comorbidities of illnesses that would make her sicker. So I think there is a decision that is appropriately tailored to the best suitable decision that a patient is most comfortable to have. So I think what has happened in the MS world is that there has been a huge thrust in developing new drugs and agents. What we never had about 3 decades or 2 decades ago, now we have so much surplus that it becomes difficult as a clinician to also make the best judgment and decision for the patient. And that's, I'm being very frank, and I think most of us sitting here probably echo the same sentiment. Never said so, we divide our decisions based on how the drugs overall behave in their efficacy and their safety. So if you are seeing a person and you are discussing with them about the disease modifying treatments, let's say the first event of an optic neuritis, and with limited brain lesions, fully recovered optic neuritis, it is our responsibility to tell them that there are drugs which have different levels of efficacy. Now I've had patients whom I've discussed, and we've talked about what we call the medium or a moderate efficacy drug, and it all comes from data which is not head-to-head compared. When we talk about science and medicine, we want to know if one drug is definitely better than the other, and is the second still better than the third. But it is not going to happen in MS world that you will have comparative studies done from one drug against the other for all the drugs. They are available for few, but the data is generally driven from a single agent, and then we look at which population it was used, what is the effect compared to the other drugs. So there are clearly what we call the moderate efficacy drugs and what we call the highly effective drugs. And within the highly effective, there are two extremes of drugs, and the highest extreme is the autologous hematopoietic stem cell transplant. So if there is a starting event in a patient and he's more comfortable starting with a moderate efficacy drug, understanding the fact that, okay, his event recovered well, the lesion load is, relatively limited, he has no disability, it should not so happen that we don't explain him the difference between how a highly effective drug may silence the disease completely versus a moderately efficacy drug, which efficacy is less, but for that patient it is not necessary that it will not silence the disease. That's important. So please understand that if you are someone who's more comfortable with the moderate efficacy drug because that's what you prefer to take based on safety and efficacy, you have the freedom to choose that, and that's what we call the shared decision making model. But if you are someone with 2 events within 5 months, with 1 event not recovered properly, it's my responsibility to tell you that you need to move to a highly effective drug because we need to now silence the disease because it's not behaving the usual way it should behave. So I think as a clinician, it's my responsibility to gauge also the requirements of an individual and make my judgment based on the best scientific capability that I have. But at the end of it, I have a very clear disclosure. Sometimes even I am uncertain. Am I making the right choice in someone by pushing a medium efficacy drug, or at the same time even pushing a highly effective drug? But I think in most of the circumstances, we do well, reasonably well.
Yeah, so because as you said that there are hardly any head-to-head comparison between the drugs, so choosing is a bit of kind of a blind game goes on, but it is essentially based on the efficacy and the safety data that has happened from the randomized controlled trial of a particular drug, and if that's good, then the doctor usually suggests that. But of course, as you said, in the shared decision making process, you are the person who is going to be informed about it, and you have to take a conscious decision of which medicines you would like to take. Rajesh, which one, oral or injectables?
Sir, I would prefer to prognosticate the patients. Right from the day one, you can guess who's going to get into a disability or who's going to do well. This is primarily based on various prognostic factors. There are patients with brain studded with lesions, nothing in the spinal cord or brainstem. These are the guys who do pretty well. They have no disabilities in the long run except for some cognitive dysfunction. And there are patients who have very minimal spinal cord lesions or 1 or 2 medullary lesions who end up in disability in the long run. So once we classify them as good prognosis, bad prognosis, males, age above 40, or infratentorial lesions, motor disabilities at onset, these are the persons who are going to get into disabilities. Here, there's no question of starting a oral medicine. Most of the oral medicines are weaker drugs. So here it's important to go for a highly effective therapy like the biologicals, rituximab or ocrelizumab or natalizumab for that matter. Those who have a more benign course of disease, primarily sensory symptoms, optic neuritis, who have had or a long history, so you dig it out, you say that something has happened 15 years ago. These are the guys who are not going to get into disabilities. Here, any of the oral medications should be reasonably fine for them.
Yeah, I generally agree with your idea, but I think at times it becomes very difficult to predict that which one is going to go in which direction at the beginning. And although there are some scales and there are some markers that are available, but at times it becomes really difficult for the physician to decide. And the body of a particular patient reacts in a particular manner. So it is a mystery to me for 30 years of practice that I've seen where I have given a prognostication of bad, the patient has done really well, and then people who have given the prognostication good, they have done really bad. So this varies, but generally I think that's okay, that when you see the disease load is much more, the relapses are occurring very frequently, so obviously you need to escalate, you need to go on a harder therapy, and if the disease is quiet, the disease load is less, then probably you would like to go for at least offer a relatively benign therapy. But I'll remind you that MS is not a benign disease at all. It is going to progress over a period of time. So one has to be careful about it and not take the disease lightly, and a continuous monitoring and treatment is required. Dr. Netravati, what is your call on the latest things like stem cell therapy or the alentuzumab that has come up in the MS field as a treatment?
These stem cells and alemtuzumab, it is almost similar. Only thing is stem cell is more of you require a proper institution, a specialist to do. Alemtuzumab is like a medical stem cell therapy, I would tell it. So always remember, this is not going to be the first drug of choice. Both are not the first drug of choice to be given when a person is diagnosed with multiple sclerosis. We should start them on other medications depending on where they are. That is, we take like a lot of, both Iyer and Dr. Debashish told about taking a lot of factors into consideration. That is the clinical radiology. We take a lot of factors and try to see where this person is fitting in and try to give the correct medication to them. So when we see that after giving the correct medication, they are failing, that is, they are continuing to have relapse, they are continuing to have disability, or there is no relapse or disability, but they are having cognitive disturbances. They are complaining of memory, they are complaining of behavioral changes. So these are some of the invisible symptoms which we may not pick up on the usual scales, but give credence to that also. So if you find that all these are progressing even after giving at least 2 higher efficacy medications, then I think we should be trying on
So-
both stem cell as well as alemtuzumab.
Ceiling kind of a thing.
Yes.
Right. Okay. Right. So, Dr. Vineeth, can you tell us about the symptomatic treatment MS, which is hardly discussed in most of it? I think that MS patients, besides the neurological problem and besides this, entire range of DMTs that are available, they also need a lot of symptomatic treatments for their symptom control, right? There are lots of other symptoms besides the motor disability that may come in fact, even the motor disability. So can you just tell us about what developments have happened in the last decade about the symptomatic treatment?
So for symptomatic treatment, I think something was discussed earlier on also regarding, say, bladder, if you have incontinence, and differentiating whether it's an overactive bladder or if it's an underactive or storage disorder. So some drugs that we had discussed, anticholinergic drugs are available. You can even give vesicular Botox injections can be done. Of course, that has to be done in a multidisciplinary team setup. That is about bladder control. And if it's a storage problem, you will have to use pads. It's refractory to medication. So you will have to use other means to be able to help them out, CIC or other things. Regarding pain, pain is also a problem in MS. For that also there are very good drugs that are available to help with pain. Spasticity, it's a very common problem. So many of our patients struggle with spasticity. There are drugs, there are other mechanisms. There is Botox if it's focal. There is also baclofen pump that's available for patients with advanced, very difficult to manage spasticity. These are some symptoms, and there are so many. Fatigue also. Fatigue is a very important complaint, and it's very hard to gauge it, but it's a very real problem that patients with MS face. Even for fatigue, there are medications that can be tried, although I'm not sure how effective those medications are compared to in other symptoms. But there are drugs that are available for that as well. So there are many symptoms which keep coming to our patients, and each one of those symptoms have treatment. That's probably the message I want to
yeah, so I think the message is that don't shy away from sharing those symptoms with your clinician, with your doctor, because there might be a solution for that, and even that can improve the quality of life, besides the MS problem as such. That can vastly improve the quality of life. And for example, just now before starting this program, one of my patients was saying that, I had this walking difficulty, and there is a new drug that has come for the walking difficulty. So she's walking is much better, and her entire life has changed. The quality has improved. So do not undermine the symptomatic treatment. That is a message that we would like to give. Right. So Dr. Mukherjee, now the monoclonal antibodies have exploded the MS treatment landscape. There are lots of them now, but we have been using a lot of rituximab in India, and also I think even outside also. So what's your take on this monoclonal antibodies in MS?
So they are definitely to stay. When we say, just for the convenience of people, it is rituximab, Ocrevus, Ofatumumab. These are the three which are easily available in the country, and we use them frequently. I don't think there is any comparison which says this is better or that is better. They're all efficacious. The question is of choosing it for the right person. Now, rituximab happens to be cheaper, and there are biosimilars, so it becomes cheaper, whereas Ocrevus and Ofatumumab, which are the other two drugs, are expensive. Now, I think they are efficacious, and they should be tried in all patients who have highly active disease. In fact, anyone who is having frequent episodes of relapse, remission, they should be exhibited to this drug, cost not being the issue. So patients who come, even with the first patient who comes with frequent relapses, extensive lesions, they should be given the...
And the initial concerns about rituximab, about the safety features, that is now generally been given, that's found to be pretty safe for neurological purposes also. Because it has been used in rheumatology and oncology for a long time, but now for us, the safety factor has also been...
In India, most of us are using it, and it is quite efficient and safe.
Right. Okay, Dr. Manjari, yeah.
Take your mic, sir.
Should know, and there is someone from the government here, which is good, is that rituximab, after a long challenge by the MSIF, finally got into the WHO essential medication list And I think it should be provided to all patients who have this disease free of cost in the country.
Yes.
I'm a very strong propounder of therapies which should be provided free to patients. And it is not an expensive drug. If you calculate its requirement on an annual basis, the range of requirements my patients get on an average just about 8 to 9 months. I don't even follow 6-monthly regimen in every patient. Sometimes they even come down to 12 months if they're doing very well. We monitor them, of course. And the total cost of a generic 6-month or 8-month therapy would be anything around 8,000-9,000. That's not a big deal, honestly speaking. And if you give treatments to people free, which are monthly 500 or 1,000 rupees, there are a lot of people who get free treatments. I think that's something that needs to be seriously worked upon.
So is your institution getting it free?
Not yet, because it's not.
Not
I
yet.
mean, we have put it, but I'm just saying that it is in the EML list now.
Right.
in the
So
country.
I think that, many of the institutions like ours are getting it free. I think RML is also getting it free. But I think we need to make it a general rule throughout India that at least, this group of drugs should be, which are in WHO list, because we were there, Dr. Padma was there in that particular committee. So we think that these drugs need to be given free for the betterment of the patients. Okay, Dr. Manjari, can you tell us about this, there has been always a concern in the patient mind that whether to use the generics, the biosimilars versus the original product. So what do you want to say to them, right? Do they work well or?
So yes, this is a very important question because India is the powerhouse of generic medications. And we should be proud that we have bioequivalent molecules available to us as a substantially low cost, So compared to what their original molecules were when they were patented by the makers, which were like 3 or 5 times more expensive, our pharmaceutical industry has managed to do bioequivalent studies and produce these molecules at much inexpensive rates. So the Indian pharma industry, of course, I'm not the spokesman for them, but generally we do a good job of it. Now, the problem there is how to do a quality control, because there can be one company who's done the bioequivalent study and come out with the molecule. There can be 10 who have done it. And we don't know if all 10 are the same. So there needs to be a quality control, there need to be periodic checks, and this is of course the job of the government, the DCGI, to look at the data after use of these molecules. So because one does know that at times there can be a slip between the cup and the lip, and you could have a substandard molecule, but that's not for us to generally I think as clinicians, when we use the molecule and we use it again and again, even if it's a generic, which we are doing now, we gain confidence, seeing that the patients are doing well on these generics, whether it be for multiple sclerosis, whether it be for cancer. Believe me, all cancer drugs are now generics, made in India. So I think generics are here for us to stay, and they're less expensive. They make it easier for patients to get the most advanced molecules in a country like us.
Yeah, I think she is absolutely right, because when I started my career, it was so difficult to prescribe MS patient the drugs because the drugs were so costly. But now a host of generic drugs have come, and over the years we have been using them, and we have found that more or less they are okay. I mean, at least for the initial stage of the disease, they are doing reasonably good. Now, Dr. Rajesh, a very important question that has been raised in the previous session also, that what are the safety concerns that you would like to see in patients while treating the patients with the drugs, and in general MS patients taking other medications as well. So what are the safety concerns that you would like to discuss with your patients?
So two important aspects. One is the maintenance of NADA, that is no evidence of disease activity, which we should try to ensure at all costs. Second is to prevent any opportunistic infections and other types of drug-induced complications. So it entirely depends on the type of molecule that we are using. And primarily, many of the medicines, except for interferons or glatiramer, are immunosuppressants. So we need to warn patients about what kind of infections they can get and what are the things they need to do to prevent infections. So now that probably the 4th or 5th wave of COVID is going to come, most people with immunosuppressive therapy should take care against respiratory viruses. And some of the drugs like dimethyl fumarate might require monitoring of the liver functions, and if somebody is on monoclonal antibody like rituximab, the routine blood monitoring needs to be done. And most importantly, suppose somebody is on a monoclonal antibody like rituximab, we need to check their blood parameters before the next dose. Instead of blindly treating them, ensure that the immunity is not totally knocked off. Give some time for the immunity to reboot and then give the next dose.
Right. So I think, you will be happy to know that most of the centers who are doing dedicated MS work, they have a kind of a checklist of what to do before they start a potentially difficult treatment, which can have some side effects. And also on follow-up, they regularly have this checklist filled up that these are the investigations and these are the points that I should look into for the patient's safety. So patient safety are very important for us, and we can assure you that that is the most important, probably the part of your treatment paradigm with which the patient is adherent to the treatment. If the drug is not safe, it is causing a lot of problems to the patient is not going to continue with the drug, and therefore the entire benefit will be lost. So last, just one liner, that if you have a message to the MS patients today, so one by one, each of one liner, give a message to the MS patients.
So don't get worried about the diagnosis of MS. Get the best treatment possible, and keep your exercises going on. Keep your spirits at the highest. Rest will take care.
Okay, Rohit.
Stay positive and let the doctor take.
But you have said confusional state three times.
Confusion. No, what I
How can they stay positive when you are saying that I am confused?
No. I'm not. It's not about my confusion. It was just saying that I think a lot needs. So I think one principle which I want them to follow is that when you visit your doctor, have the right to tell him or her your problems. Sometimes with the want of time or shyness or any reasons, they are not able to. I think there is a time problem.
So don't hesitate to ask and barrage of questions to your doctors. Don't hesitate with that. Vineeth.
So every aspect of your disease has treatment. So that's just something that, and the treatments are coming. There's a lot of new.
So MS is treatable. MS is controllable. MS can improve your quality of life. So do not be afraid of MS. That is the message.
I think I'll echo this. If you are diagnosed with multiple sclerosis, please don't read that it is incurable. No, it is not. I will not say it's curable, but I will say that it can be highly controllable, and have faith in your doctor, and you can lead a normal life.
Okay, Manjari?
I think they should not fear the disease, and most importantly, what I see at AIIMS is that patients have been started on medicine and they stop it, and then they come back with several relapses. So please do not discontinue your medicine based on hearsay, based on your feeling, or based on your community or your neighbor's feeling. Please, before you even decide to stop your medicine, visit your doctor and take their opinion. And definitely these medicines, there are middle part drugs, there are very high potency drugs, and anything can be prescribed to you to make you a meaningful individual in this community. Thank you.
Good. Netra?
MS does not have cure, but next to cure is to have complete control. And MS is something which you can completely control with all the symptoms. Thank you.
Right. So, ladies and gentlemen, we conclude this session, and I say thank you. Now, a lot of water has flown since the time of original description of this disease by a French neurologist called Jean-Martin Charcot way back in 1700. And now we have got the drugs to control the disease, to understand the disease, and to have a newer agents. By and now, we are getting, this news that newer maps are coming up. So I think we have a great hope and great future for the MS patients. And thank you very much for this wonderful listening. Yeah.
We would like to thank the moderator also.
One question, because they said that questions will be outside the tea. Yeah.
No, this is a very important, because we have our MS family. Okay, head turning back. Okay, but yeah. So we know that in 2022 there was a national registry which was launched by ICMR on multiple sclerosis. I don't know if this is the right time, but I would really like to know, because I had led that petition to actually seek that national registry. Do we have a data, especially I know that because Nihans was one of the hospitals which was in the list. Do we have any data as to how many people with MS have been recorded in these 21 hospitals which were under the national registry in India? Any data of people with MS that we have?
Rohit.
Yes, Rohit, sir.
Yeah, so the registry is very well ongoing, and hopefully maybe in the next month or so we should, maybe in the next month I won't say, but in another 4 to 6 weeks, we should be able to, we'll be submitting the first manuscript in about 2 weeks, 3 weeks from now, and you know how journals are, they take time to review, but the currently overall estimate of all demyelinating disorders, we're almost touching close to 4,500 plus patients.
Okay, okay. Thank you. Yes.
Dr. Rohit, there is a gentleman sitting over here. I think you said 12,000 people are taking GIPMER certificates, MS. So I think a coordination of this sort, I mean, who are they? You can find out. You have 4,500, you put 12,000.
Yeah. So you see that Vipasha, that a lot of patients are still not captured because they are in the periphery, but so we are making, I mean, Rohit is making a lot of effort for that.
So registries are pragmatic. They depend on, this is a hospital-based registry. It's not a population-based registry. To do a population survey, you require to sample lakhs and lakhs. We really need to sample all the population, because we truly, as of now, do not know the exact prevalence. We have an estimate of prevalence. So even if your estimates, which were thought to be 20 before 10 years back, are now, let's say, 40 or maybe even 40 to 60 per 100,000, you can estimate that the number of population that needs to be screened to get it. This is a hospital-based registry at these multiple centers across the country, and within those centers also, every patient may not get recorded into the registry. Some may decline to be a part of it, some may get missed due to busy OPDs. So it's a process in evolution, and they keep on getting entered as and when they get registered into the registry. So that's it.
Okay. Thank you, ladies and gentlemen, for kind listening. Thank you.